I think Ram will be joining us soon as well, so if he's not already on there. Anyway, welcome everybody to Western Canada CTO rounds.
Yep.
I'm grateful for everyone to find the time on their evening to join us. I'll be. Can everyone mute their microphones, please?
Maybe.
Yes.
Yeah, obviously.
Okay.
We didn't do that, did we?
Can everyone mute? Yeah, thank you. So I'll be co-moderating this session with Ram and Bassem Al-Barouni. Today is very exciting. I mean, it's a great honor and pleasure to kind of host Mauro Carlino. So Dr. Mauro Carlino he's a great friend, mentor, teacher, and I'm very grateful for him to wake up at 3 in the morning in Italy and to spend time with us and to teach us about HDR. So as I say, Dr. Carlino needs no introduction. He's a worldwide renowned pioneer and a key opinion leader in CTO PCI, having performed more than 2,000 CTO PCIs, published over 300 peer-reviewed articles in complex PCI and CTO. I think it's a great honor to have him here and to talk to us about his new strategy of HydroDynamic contrast recanalization. As I say, he's well known for his Carlino technique. That needs no introduction. Every day we perform CTO PCI, and certainly in my lab, I'm mentioning his name every day because I'm using the Carlino technique. So it'd been very nice to hear his perspective on the Carlino technique and the new HDR strategy. So what we'll do is I'm going to hand you over to Mauro Carlino. He'll talk to us about hydrodynamic contrast recanalization. And then following that, we'll have about 20 to 25 minutes of question and answers. And then shortly after that, we need to stick to time, and then we'll move on to 3 cases. The 3 cases are unique in themselves that we'll present different cases, and then we'll get Mauro to talk about each case and to kind of explain his perspective on how HDR could work. Later on in the presentation, we are also going to have Dr. Salman Orion, who's also a very important person in HDR. He's worked together with Mauro Carlino, myself, and a whole bunch of other authors that were on the HDR paper. And it'd be nice to have his perspective. I think he's tied up in a meeting in somewhere else. So as soon as he will join us. So over to Dr. Mauro Carlino. Please tell us about HDR. Thank you so much.
Okay. First of all, I share my. Can you see my screen? Hello?
No.
I'll share again. I try.
Yes.
Okay. Just a moment. Well, thank you, Bilal, for this kind presentation. I'm very happy to be here, and it's a big honor sharing with the Canadian community this experience. And I want to do also a little bit of story of the contrast modulation, and it's a big pleasure to be here. So you feel free to stop me when you want. I like to have an interactive meeting with you. Well, this is the talk talking about the last evolution of contrast modulation in CTO PCI. The hydrodynamic contrast recanalization acronym is HDR, which is a new integrated CTO crossing strategy. Well, here the outline of this presentation. I would like to provide a historical perspective on the use of the contrast modulation in CTO PCI. I want to explain its pathophysiological rationale, technical recommendation, how and when to perform this maneuver, and future direction. Well, first of all, I have to define what is a contrast modulation. Contrast modulation in CTO PCI refers to the modification of plaque compliance achieved through an intraplaque contrast delivery via a microinjection. The injection of contrast medium for CTO recanalization has undergone a long dynamic journey since its initial formulation. And here is a review of all my experience over the last 20 years. Well, first and foremost, this experience would not have been possible without the influence of Antonio Colombo, which is my mentor and pioneer, is a pioneer of interventional cardiology. And our professional relationship and friendship have been instrumental in helping me develop significant expertise in both clinical and research aspect of CTO PCI. Well, here a figure showing human evolution stages, and I did another figure showing contrast modulation evolution stages. And this history started with the peripheral star and was followed by the coronary star, which is, you know very well, the coronary star technique has arisen from a similar concept utilized to open occlusion in a peripheral vascular system and has been proposed for recanalization of difficult CTO. Well, star and peripheral star are not a contrast modulation technique. They use a wire-based approach to re-enter the distal true lumen effectively. STAR does not utilize contrast media in accordance with the contemporary CTO dogma to avoid contrast injection in the subintimal space. Do not forget that at the time, if you went intentionally or not in the subintimal space, this was considered an ominous situation. And I remember that implanting a stent was considered something that was not, I would say, dignitous. And during live cases, I remember that operators try to do all their best in order not to implant the stent during the live transmission. But at the end of the procedure, they implanted the stent in case of a big dissection. Well, the STAR was the first wire-based ADR method to treat unfavorable CTOs, which is, from the philosophical point of view, the importance of this technique. This technique gave us the ability to manage the extra plaque space, and this has been a critical step in dramatically improving the success rate of contemporary antegrade and retrograde CTO PCI. In effect, STAR increased the CTO operators' confidence in treating this complex lesion by pushing the boundaries of the vascular architecture into the extra plaque space, safely navigating it with the knuckle, and ushering the utilization of a vast array of techniques later to be included in the hybrid algorithm. Well, the true story of the contrast modulation was born in 2008 when I published a paper called the Contrast Guide STAR. And in the same year, I published another contrast modulation technique, which is the microchannel. Few years later, I published a paper describing in details what is the Carlino technique. And a few months ago, I published the HDR that we will discuss in short time. Well, to date, I don't know what the next development will be, but I'm sure there will be. Well, here the paper talking about this STAR with contrast guidance. These represent a paradigm shift in the field of CTO PCI because it was the first example of safe and effective use of contrast modulation in this setting. Basically, with this technique, with the forceful injection of large volume of contrast, I tried to perform an hydraulic recanalization of the vessel, breaking the flap of the dissection, separating the false and the true lumen. Which was the birth of this contrast guided STAR? Here, this is a very interesting case I performed almost 18 years ago. You can see a right coronary artery reopen with the STAR technique. You see a very big, long spiral dissection, but the TIMI flow is very good. Well, what is interesting is that in this posterolateral branch, there is a side branch with an occlusive dissection, as you can see. And even during the stent implantation, you can see here the contrast staining in that area. Well, after the stent implantation and the check from the guiding, surprisingly, I see the recanalization of this vessel. So I thought a lot about that, what happened. And at the end of my thought, I realized that probably the column of contrast arriving from the guiding entered in the cul-de-sac of the dissection and basically break the flap of this dissection, created a communication, a fenestration from the false and the true lumen. That's the reason why you can see the recanalization of this vessel. And so, according to this picture, I try to realize intentionally the injection of contrast to reopen artery. And this is an old experience of mine, here an occlusion of a circ. And basically here the contrast guide start with the forceful injection with a big amount of contrast. Look at here, I was able to reopen the artery. I know now these are unconventional picture, but you have not to forget that at that time there was no any device to reopen the artery. So this was an attempt of trying to follow a new wave for reopening artery, and this is the final result, which is not so bad. Well, here the different. The conventional star use a knuckle pushed, and you can see here the typical jerk of the wire when it re-enter. And this is a very interesting picture I recorded. You see an occlusive dissection. Here the knuckle advancing. You can see exactly the exact moment when the knuckle break the flap, and you see the contrast disappearing in this area. And this is a sign of reperfusion of the vessel. And this is a contrast guide star. Here you can see a microcatheter injecting contrast. In reality, this is not a microcatheter. This was an over-the-wire balloon. At that time, there was no microcatheter. This is an over-the-wire balloon. And from this, I inject contrast. You can see here the cul-de-sac of the injection, of the dissection. And you see also the break of the flap and the communication with the distal true lumen. Well, which was the importance of the contrast guide star? This technique gave me the confidence to safely inject contrast in the extraplaque space, challenging the dogmatic assumption of not injecting contrast in this area, and give me the opportunity to recognize and manage differently unusual and ugly-looking radiological patterns made by contrast in the extraplaque space. Namely tubular and storm cloud dissection, and how to transform storm in tubular dissection. Here, what is the, sorry. Here, a tubular dissection, which is a dissection with a linear morphology consistent with the vessel outline, probably because the contrast lies between the media and the adventitia of a large vessel, as a subintimal space can accommodate a considerable amount of an injected contrast. And this is the so-called storm cloud dissection, which is a diffuse and inhomogeneous staining of contrast media that is often confused with the perforation. And this angiographic picture is seen following contrast injection into a small vessel whose subintimal space cannot accommodate the injected volume. You can see here in a picture showing this storm cloud dissection. And you can see also in another projection the periadventitial distribution of the contrast, which explain that this is not a perforation. And this periadventitial distribution probably correspond to a transient alteration in vessel permeability, which usually self-resolve within a few minutes. Look at here, this is a tubular dissection. This is storm cloud dissection. And I was able to transform, and I show you in short time, this storm cloud dissection in a tubular one. In which way? Here, an occlusion of the right coronary artery. You can see in the white dots shows the course of the main branches, and the yellow dots show a little side branches. Well, during the procedure, I advanced the guide wire, and later I realized that it's not, as you can see from this zoom, I'm not online with the direction of this this vessel. So I'm close to these side branches, but outside, probably in the extra plaque space. I injected, and look at, this is what happened. This is the stone cloud dissection. Basically, here the over the wire balloon from which I inject the contrast, and in order to recover a more safe situation, I pull back the microcatheter, you see, in this situation. I re-inject, and here the distance is much more bigger than before from this point to this area. And basically, I push back, I pull back over the white balloon, I inject, and you can see I draw the main course of the vessel. And in doing that, I followed this area. I was able to reach the distal true lumen, and this is the final result. So in summary, here the storm clouds during the procedure, here the disappearance of the storm cloud on of the small side branches at the end of the procedure, and here the reappearance of the vessel at 3 months follow-up. And look at this case, it's very interesting. This is an occlusion of the right coronary artery. I inject contrast. There is a formation of a storm cloud dissection. And again, I do a small injection again, and you can see a recanalization of this vessel. And this is the proof for sure that this is not a perforation. And look at here, at the end of the procedure of a stent implantation, you can see the reappearance of this vessel completely healthy. So this is not a perforation. Well, unfortunately, the STAR, contract-guided STAR, are approaches that have been associated with extensive vessel injury and unpredictable true lumen reentry, which were in turn associated with high rates of restenosis on follow-up. And so I decided to do a next iteration of the contrast modulation, which was the microchannel technique. I started using a smaller amount of contrast medium by gently injecting it just beyond the proximal cap of the CTO. At the time, your and my friend, the Canadian guy, Bradley Strauss, described the presence of endoluminal microvessels within the occlusion in the experimental CTO models. And my initial suggestion was to perform microinjection to recruit these intraplaque microchannels and facilitate subsequent true-to-true lumen crossing with the polymer-coated wire along path of least resistance. But I was wrong. I was wrong because this endoluminal microvessel resulting from reorganization of thrombus within the occlusion, which was in size less than 500 millimicron, ran longitudinally within the occlusion parallel to the major axis of the vessel. Here, the three-dimensional micro CT showing the CTO entry of this microchannel, and here the CTO exit. But as you can see, these microchannels are not continuous and are too small to be crossed by a 0.14 guide wire. So the microchannel technique has later evolved into what is currently known as the Carlino technique, where a minimal volume of contrast is gently injected inside the occlusion with the goal of modifying the plaque compliance to facilitate, again, guide wire crossing and microcatheter advancement through a fibrocalcific plaque. This is the Carlino technique. But the description of the Carlino technique has been presented at different forums in a way that differs markedly from its original description, utilizing this term to refer to any form of contrast medium injection within the occlusion. But what exactly Carlino technique? I explain in this letter what exactly this letter was published on air intervention, and I published two papers describe in details this technique. So I suggest you, if you are interested in this topic, of reading these two papers. Basically, Carlino technique is not a method to reopen CTOs, is not an hydraulic dissection, but is an intraplaque injection of a very small amount of contrast media with the primary goal of modifying the compliance of the plaque, striving not to extend the contrast into the subintimal space. And when to do it, the Carlino technique, when you have to modify the compliance, the plaque compliance, when you have to resolve ambiguity, you can do it in the proximal distal fibrous cap or in the occluded segment, and is applicable to both anterograde and retrograde approaches. There are a lot of different use of Carlino technique here, a sum of the paper talking about Carlino technique in different contexts. But now let's talk about the last iteration of the contrast modulation, which is the HDR technique. HDR is the sum of the lesson learned from previous contrast modulation technique. Here, the paper was published no later than last September, and even if it was just published, people quickly became interested in this technique and began talking about it. Here, a friend of mine, which is Dr. Nikita Brendea, which is a Romanian guy, and he discussed at the last EuroCTO club how did the HDR changed his antegrade approach. Or again, the same guy on LinkedIn talking about Carlino Magic Fair dust, also known as HDR technique in a successful case of CTO. Here, my friend Manos Brilakin talking his podcast on YouTube, again, discussing with Salman Arain a case of hydrodynamic contrast recanalization. And what is surprising for me, even a Japanese guy, and here Dr. Fujita, which is a high volume operator in Japan, support.
Yeah, I like this secrets mode shape plyout Carmen, if you want to go there.
It almost seems like too much.
Hello?
Can everyone put their microphones on mute, please? Thank you.
Okay. And so I was really surprised because was a wonderful surprise because usually Japanese operators are reluctant to accept novelty in the field of CTO PCI. And this is a comment of a guy from the Boston, which was present in my stage in Houston 1 month ago, where me and Rain performed a few cases using this technique, and they discuss on X saying, I just spent a few days with Rain and Carlino learning this modified technique. Very impressive result, a lot more straightforward than I thought it would be. And I was just 1 month ago in Beijing, and I was invited because even this in that area there was interest in this technique, and I was invited at the 35th Great Wall International Congress in Beijing. And there is a lot of question and answer in social platforms. So basically, there is a great deal of curiosity about this technique, accompanied by a desire to understand it better in order to apply it, since it is, in fact, a simple technique. Well, which is the mechanism of this technique? The HDR technique can be equated to a concept of the path of least resistance. This is a metaphor that describes the natural tendency to choose the easiest or least demanding path to achieve a goal or to overcome a challenge, avoiding unnecessary effort and obstacles. This concept in physics applies to how things like electricity or water flow. Electricity will follow through the wire that offers the least resistance, and water will flow through the easiest path, like a slope or a crack in the ground. In psychology and in the everyday life, choosing behavior that requires less effort is a part of human nature. So I try to apply the concept of path of least resistance to CTO PCI treatment. Here, the background of this technique, HDR is a novel technique that enables primary intraplaque wire crossing during CTO PCI and this technique involves an intraplaque contrast delivery via a microinjection to modify the plaque before the passage of a polymer jacket wire. Well, the knowledge of the anatomy and the histopathology of an occlusive plaque in a CTO may explain why this maneuver can be effective. And here in a histopathological specimen showing a hard plaque intermingled with soft plaque. And here again, this picture with a three-dimensional microcomputed tomography of CTO showing again patchy fibrocalcific content intermingled with loose tissue segment formed by cholesterol-laden cells, foam cells, and neovascular channels. Well, suppose hydraulic forces are applied through a solid occlusion by a soft injection, delivering a small contrast of volume. In that case, the contrast will follow path of this resistor represented by the loose tissue segment in the occlusion. And this maneuver is aimed at recruiting the soft part of the plaque, so soft injection. But if you increase the amount of contrast or or perform a strong injection, area of high resistance inside the plaque will divert hydraulic forces to a radial direction involving the extra plaque space, which is usually softer than intraluminal obstructing material and lead to contrast extravasation. Well, here the way how to do it, the injection, you have to do a very gentle injection of a very small amount of contrast, and the tip injection must be performed in a controlled manner under fluoroscopic guidance. And this approach allowed for tailoring both amount of contrast administered and the force of injection to each individual case, as this parameter depend on the anatomic characteristic of the occlusive plaque. Here, the correct injection, but if you insist in injecting, you can transform this injection in an uncontrolled progression of the dissection due to a powerful injection. Here, an example. Well, here, description of technique. Basically, you have to advance a microcatheter over a floppy wire, abutting the proximal fibrous cap, exchange the floppy wire for a dedicated CTO guide wire according to the preference of the operator, penetrate the proximal fiber cap centrally for only a few millimeters, advance the microcatheter into the proximal part of the occlusion while simultaneously withdrawing the guide wire, and gently release less than 1 milliliter of undiluted contrast using 2.5 milliliter syringe through the microcatheter while acquiring cine images of the occluded segment. And here, a video basically explains the same mechanism. You can see here the wire punctured the proximal cap, pulling back the guide wire, advancing the microcatheter, and delivering a small amount of contrast in order to recruit the soft part of the plaque, modifying its compliance. And here, a soft polymer jacketed wire crossing easily this plaque. And there are several possible outcomes after the intraplaque contrast release. It's impossible to inject contrast due to a resistance. That means that you are again inside the plaque, and so you have to advance the guide wire 2-3 millimeters further into the occlusion and repeat microinjection. Or you can get it's called pattern number 1, which is an intraplaque diffusion of contrast with staining and patchy appearance. And here this picture showing a localized blush of contrast with a patchy distribution inside the occluded segment. This patchy stain denotes infiltration of contrast into soft lipid-rich areas of the plaque without involving the calcific part, the hard part of the plaque. Side branches originating from the injection area within the plaque are proof that the injection was indeed intraplaque. Here are side branches. Or you can see a pattern number 2, which is an immediate visualization of the distal true lumen. And type 2 pattern denotes successful intraplaque crossing of contrast into either a distal true lumen, and this is we call the type 2A, or in a side branch, this we call the type 2B. Pattern 1 and 2 can be simultaneously present. Here a picture from the paper. Here the tip 1, so the patchy distribution inside the plaque. Here the type 2B, you can see here the microcatheter injection showing side branches. And this is type 2A, injection and immediate visualization of the main branch. Well, which are the mechanisms underlying pattern number 1? We hypothesize that a patched contrast stain simply denotes its infiltration into soft, repeated, rich areas of the plaque, while mechanisms underlying pattern number 2 are probably occurs when the soft area within the plaque are well represented and the interaction with contrast create a kind of mechanical washout, generating a large path of lead resistance for wide passage across the CTO, forming basically a macro channel. Here a case is an occlusion of the right coronary artery. You can see here a fielder XT fails to cross even with the microcatheter support. So I puncture the proximal cap and we perform a small injection of contrast. And you can see here a contrast modulation of the plaque of the main vessel. Here, the steel frame, you can see here the staining of the plaque and the appearance of side branches from this area. Well, after this injection, you can see in how easily the field XT crosses the occlusion. And here, the angiography after a small pre-dilatation with a 2-0 balloon before performing IVUS. And you can see also the preserved side branches in the area of the occlusion. Well, this is the IVUS finding after HDR, and you can see IVUS pullback images from proximal cap over RCA with branches to distal cap exit into the true lumen. Well, you can appreciate that the IVUS catheter is intraluminal at each site. And another interesting aspect is this vacuolic effect of the plaque. And this is due what we define the speckled sign. Speckled sign is eccluscent areas within the occlusive plaque, but not proximal or distal to it, and probably is a soft plaque saturated with contrast. This IVUS sign confirms intraplaque contrast tissue modification. Here are few cases. You can see here an right coronary artery occlusion, here the puncture of the proximal cap, and here the injection. This is a simultaneous pattern number 1. Here the patch distribution inside the plaque, and you can see also a big side branches originating, and also the main branches originating in this area. And you can see how easily was the crossing of the wire with a fielder, and this is the fielder redirected into the true lumen. This is the intraplaque track showing angiographically after a small pre-dilatation, and this is the final result. You can see even after stent implantation, preserved side branch on the occlusion site. Look at this, which is not an easy right coronary artery occlusion because there are a lot of bridging collateral. Well, I advance the guide wire, I puncture the proximal cap, and I inject. You can see here the classical patchy distribution of the plaque, and you can see also in which way easily the wire cross the lesion. Again, here you can see the intraplaque track after a small dilatation. There is no concern about getting a hydraulic dissection because I'm for sure intraplaque, and this is after stent implantation. Here another RCI occlusion, and here the puncture of the proximal cap. You can see the injection, and you can see immediately the distal true lumen, as you can see in this circle, and you see in which way the guide wire cross easily the plaque, and this is the final result. This is a short occlusion, but very calcific. I performed a few weeks ago. You can see I punctured the proximal cap here, and I inject, and I had immediately the distal visualization, as you can see here, of the distal vessel. You can see here the fielder crossing. It's high calcific, and you see some resistance, but at the end, the wire found by itself the way. And then I tried to advance the microcatheter, but it was impossible. I used small balloons, anchoring balloon, granuloplastic, no way. And so I had to add the rotational atherectomy, and this is the final result. So this technique works even when the lesion is hypercalcific. Look at this proximal LAD CTO, as you can see here, with few collateral from the right coronary artery. This is very interesting. I punctured the proximal cap, and I see here a small side branches that was not visible on the initial angiography. This means both that it originated after the proximal cap in the body of the CTO and that the microcatheter is intraplaque. So I tried to advance the fielder into the true lumen, but was impossible to advance the microcatheter. Is in the true lumen, as you can see here from the microinjection, but was impossible to advance a little bit more. So I do another small injection, and with this further injection, we can see a minimal involvement of a small portion of the main branches with consequent contrast modulation in this area. I show you the steel frame. This is side branches, and this is the area with the new contrast modulation. And at this time, after this injection, you can see how easily the guide wire go in the true lumen. Then we had to use an anchoring balloon because there is a lot of calcium in order to allow the crossing of the microcatheter, and this is the final result. And I basically preview your question, and now I try to reply, which is the difference between the HDR and Carlino technique. HDR is a technique, Carlino technique is a maneuver. HDR is applied before introducing the wire into the plaque, allowing for its modulation and facilitating easier wire passage, while Carlino is a maneuver and is applied when the guide wire stops moving. So in short, in HDR, contrast comes first, while in Carlino technique, conventional contemporary CTO PCI treatment, wire comes first. So in conclusion, HDR represents a new integrated interplaque method for reopening CTO using hydrodynamic forcing. It is performed using an intraplaque injection that delivers a small amount of contrast targeting the soft part of the plaque without affecting other structure, thereby modifying the plaque's compliance. And this appears to make it easier to cross the occlusion with a polymer-coated wire, such as those in the Fielder family. In conclusion, standard technique, the wire leads the way, in which the HDR contrast leads the way. Well, this is the last case, but I think there is no more time. This is a case I performed 1 week ago in Romania during a live cases. Do you want to see or not? We can
Yeah,
skip.
no, Mauro, you can show us briefly, and then we'll have a few questions and move on to the cases.
This is interesting because show how this technique can be applied even in difficult occlusion. You can see an RCA occlusion. It's a long occlusion. It probably is there are multiple occlusion in this area. Here, in the circle, you can see the first occlusion with a side branch. Here, another occlusion with another island of vessel with another side branches, and here there are a bifurcation at the crux. Well, I advanced the microcatheter, as you can see on the right, and I do an injection, and I can see the direct visualization of a side branches. I try to this is the first occlusion. Then I advance the Gaia a little bit further, and I do another contra injection here. The typical aspect of the pain, the staining of contrast with the patch distribution of the contrast, and you can see here the fielder advances step by step. Is an high calcific lesion, so it needed another injection. This is another contrast modulation you can see here, and after this injection, you see the fielder was able to advance and to engage a side branch as shown by this contra injection. So I trap the wire because I get a good position here, and in order to cross this last part of the occlusion, I re-advance a microcatheter here, and I do a contra injection here. You can see this contrast staining seems quite extra plaque. This you can distinguish a contrast modulation by HDR or a storm cloud dissection, because the storm cloud dissection maintain a persistent appearance on this area. But this gave me the relationship between the true lumen and the extra plaque space. So I advanced the microcatheter in this area, and then I advanced the the fielder FC, which reach easily the posterolateral branch. Then you see I predilate the lesion, and you see how calcific was this plaque. This is a non-compliant balloon. Before I had to arrive to 20 atmosphere in order to have a good preparation of the lesion. Then with with dual lumen catheter, I was able to engage the PDA, and basically I don't know why the final result, which is a very nice result. Okay.
Thank you. Thank you, Mauro. That was an absolutely fantastic presentation, and I mean, I'm sure you have lots more to say, and we have lots more to learn and lots of questions to ask. I'm going to start just by saying that I've started doing this, and I learned this from you and Salman, and so my practice in this technique is very early. So time will tell how my practice evolves. I see myself as primarily a high volume retrograde operator. So I'm really looking to see how my CTO practice transforms. I've started using HDR, and there are times where I've thought, actually, you know what, I'm going to be going retrograde through various channels. HDR's worked. There are other times I've tried HDR and I'm still learning, and sometimes it hasn't quite worked, particularly in those post-Cambridge long calcific CTOs. But as I say, when you use this technique, it doesn't take away the fact that you can still use your other techniques. You can still knuckle down, you can star, you can ADR, you can go retrograde, so it leaves the options open, but it gives you the potential to use a lower risk and an option with a shorter crossing time. My question is, and this is, I learned this from Salman. So once you penetrate the proximal cap, you've done your contrast injection, you've got a channel, you can see your distal vessel light up. I'm trying to learn to use a non-tip XTA. So for others listening here, what I mean by the non-tip is often when you get your wire, you make a 1 millimeter bend, or your CTO type bend. Salman uses a non-tip XTA. Is that something you have to do? In the beginning, I find it a bit weird navigating a non-tip XTA, but according to Salman, it finds a channel, finds a path of least resistance. Just wanted to know your comments on the choice of wire you use after HDR.
Well, to be honest, I have a different point of view respect Salman. I do a small curve of the distal part, such as the Mongo wire. So I do this kind of very distal folding of the distal part of the wire. And again, to be honest, when I have an injection with a nice evaluation of the distal true lumen, I tried to cross the lesion even with the workhorse wire, and I was able to do it. Of course, if there is a pattern of calcium inside the plaque, the polymer injected wire works well. But to be honest, when you inject and you recruitate a big part of the soft plaque and create some kind of washout of this plaque, you create a macro channel. In this macro channel, this can be engaged even from a workhorse wire. So, of course, if as I show you, what you get after the injection is different. But if you immediately see the distal true lumen, you can try also with the workhorse wire. About the distal tip, I think that is a minimum of tip could be useful in order to manage the wire inside the island of calcium inside the plaque.
Okay. Sanjog, you got a question?
Thanks, Bilal, and thanks, Mauro. That was fantastic. I really enjoyed that presentation. I have a question on the wire that you choose to use. So presumably with HDR creating multiple areas of I guess contrast modulation through the lowest resistance tissues, with a tapered tip on a wire, do you find that you have the tendency to get hooked up underneath plaque that maybe does not have the same low resistance phenotype as the areas that you've managed to modulate? What I mean by that is, if you inject contrast and you create several different channels through your softest plaque, but you have a tapered tip, do you not find challenge is if you're unable to navigate precisely that track, that taper tip can get hooked up behind areas of plaque that perhaps you have non-modulated as well. I learned this technique from you as well, and I learned the Carlino technique from Dimitri and the mentors that taught us. And my go-to wire in this sort of a scenario, rather than a Fielder XTA type wire, is a Pilot 200, because it's not tapered, and because though the medium tip strength can result in transition into the extra plaque space, I think if you've loosened up the tissue and you have medium tip strength without the taper, it tends to just bounce off the calcium and towards the distal cap. But again, my experience using contemporary HDR is also quite early, and so I'm eager for your thoughts.
Well, the purpose of this technique, as I told you, is to recruitate the soft part of the plaque. I'm not sure, but I'm sure that probably there is a mechanical effect. When I inject, I move away the soft part of the plaque. But probably there is also some kind of, I would say, lytic effect of the contrast of the soft part of the plaque. And the purpose is to create basically on a solid, a few macro channel, okay? Mechanically. Well, if you have a macro channel, I don't think it's a matter of tapered or not tapered tip. Is a creation of so big a space where you can cross, even with, as I said before, with a workhorse wire. So the purpose of this technique, and as I showed in the last cases, when you can use it, you can use the HDR also in a multi-stage way, is to step by step to modify the compliance of the plaque in order to create a way. And usually this way is a big way, particularly when the soft part of the plaque is well represented. So probably whatever you use, I suggest you, if you cross with a tapered wire, to try to pull back the wire and try to go with another wire. And I don't think you can find differences, particularly if the injection creates a big macro channel.
Hey, Sanjog. Hi there, Salman here. How's it going?
Oh, great to
Hi.
see you.
Hi, Salman. Thank you.
Hey,
Welcome.
Salman. How are you?
Good. I just joined. I kind of caught the tail end of your question. I'm going to give you a slightly different spin. Sort of my take on this is, I think the goal is to do contrast modulation as the start of your crossing process. And then you find out that more often than not, HDR is the result. I think the trap people fall into is that we want to do HDR, that to choose a lesion that may not be appropriate. And like you said, you may have calcium, and if you ricochet off and stay within, that's fantastic. You end up with HDR. But if you end up on the opposite side of calcium, you start seeing a stain. I think that can be very sort of off-putting for someone who's still new to the technique. So the HDR is what I think, and Mauro can correct me, that the years that Mauro has been doing this, HDR is what he recognizes the mechanism for most of these, however, not all of them. And so while the goal is to, or the hope is to get HDR every time, you're right, that when you do contrast modulation, you may not always get HDR. And then there are other ways to deal with that issue, whether you repuncture or whether you switch to a wire-based strategy. Or what you can also actually, if you're a retro guy, you can go retro at that point.
Mm-hmm.
But the goal is to modify plaque up front with contrast. And I think the problem of using the wire first is the wire makes a channel that the contrast is then committed to. So if you do the contrast first, it's very short distance, 1 or 2 millimeters. A wire, once the knuckle forms or once you go deep, then the contrast will always take that path. So that's my take on the whole thing.
Excellent.
Thank you.
I think we should just we move on to the cases, and I think because we're going to involve Mauro with each case, and now Salman's here as well to provide perspective on HDR. I think we'll have plenty of time for more kind of fruitful discussions on HDR and its techniques. So I'm just going to hand you over to Bassam, who's going to be moderating the next 2 cases. And the first case will be presented by Arjun Gupta from Edmonton. So Bassam, over to you.
Alrighty, sounds good. So, hey, for those that don't know me, I'm Bassam, one of the interventional cardiologists in Winnipeg. Arjun, who's presenting, is our former fellow and then is now practicing in Edmonton. So interested to hear his case.
Yeah, thanks, Basim. Let me just split up here. Let me just make sure I share the right screen. Okay, perfect. Can everyone see my screen?
Yes.
Yeah.
Okay. So the title of my presentation is Where is the LED? I'm an interventional cardiologist at the Mauro Carlino Heart Institute in Edmonton, and pleased to present this case. So brief case introduction. This was a 52-year-old gentleman who was admitted to the CCU following an out-of-hospital cardiac arrest. He's known to be diabetic, hypertensive, and an active smoker. And this was his initial diagnostic angiogram. See, the right has a severe lesion in the mid segment, mid to distal segment with diffuse moderate disease. There appears to be a CTO of the LAD that fills via retrograde collaterals from a large PDA. This is the shot of his left. So you can see severe distal left main disease, critical distal left main disease with poor flow down the entire left side. Not surprisingly, this patient ended up going for CABG. He had a lima placed to a diagonal, and the operative report noted that the LED was not identifiable. He had a vein graft to the PDA, vein graft to the obtuse marginal, and his EF did improve from about 25% to 35%. However, when they were closing the patient, he developed refractory VT. They checked the graphs with Dopplers, had reassuring signals, but ultimately couldn't close, and they placed him on central VA ECMO with an LV vent placed via the right superior pulmonary vein. Unfortunately, in CVICU, he continued to have refractory VT whenever they weaned ECMO, and so we were asked to consider CTO PCI to the LED on post-operative day 9, and so we agreed to proceed with ECMO-supported CTO PCI. And so the setup for this, we usually do our CTOs with 2 operators, so myself and Dr. Kevin Beatty, who I think is on the call as well. Our axis here was 7 French right femoral system and 6 French right radial system. This is the shot of the native system. You can see the LED is now almost fully occluded. Back one. This is the native RCA. You can still see some collaterals to the LED, although not as robust as prior. The vein graft to the PDA is widely patent, with collaterals that are seen from the vein graft filling retrograde into the LED system. This is the lima to the diagonal, widely patent. And then this is our dual injection vein graft to the PA and lima to the diagonal. So you can see that they did graft the diagonal. The lima kind of fills late towards the middle of the screen there. And so our conclusions from the diagnostic was a subtotally occluded distal left main, patent vein grafts, the lima to the diagonal is patent, and there's some collaterals from the PDA to the LED. And so our initial strategy was antegrade wire escalation. We did note that it was an ambiguous cap. Lesion length looked to be around 20 millimeters, maybe a bit longer. There's a large diagonal side branch that's been grafted. And so we performed AWE with a pilot 50, upsized or increased to a pilot 200. We tried to go after it with Gladius Mongo, and this was all done using a Corsair microcatheter. And then this is our tip injection after we had thought we had made some progress, but clearly we hadn't made very good progress. And so at this point, we decided to switch to a retrograde approach. Now, the trouble was the collaterals were best seen via the vein graft to the PDA, but we were concerned that our microcatheter, our wires, our equipment wouldn't be long enough to transverse the vein graft, go up the retrograde collaterals, and then back out into the LAD. And so we, knowing that the collaterals existed, we effectively kind of blindly surfed the collaterals via the native RCA, or PDA, I should say. we use a Xion wire with a Turnpike LP microcatheter. And actually, we were able to get into the LED. So this is a image of us having advanced our microcatheter up into the LED and at the distal cap. The distal cap actually ended up being quite difficult to puncture back into, but we ended up getting back into the left main eventually with a Confianza Pro 12. We then advanced our Turnpike LP into the left coronary guide, exchanged for an R350 wire, and then we were able to balloon, perform IVUS, and move on to their PCI. And I've just included this IVUS run. This is a short segment. You know, I do think at one point we were probably intraplaque, and then subintimal, and then come back into true lumen. So start true lumen, probably go subintimal for a short segment, and then come back in into true lumen. We have stenting the left main to the LED with a 3.538 Science Pro S, post-dilated based on IVUS measurements. We achieved an MSA in the LED of about 10 millimeters squared, and in the left main of about 15 millimeters squared. And this was a very long procedure, 320 minutes. We used 5.4 gray, but this was our final result. And I'll kind of open it up to discussion.
Yeah, some big challenges there. I guess I'll ask the first question to Salman and Dr. Carlino. Like, would HDR have been helpful here? Would that something you would consider? You know, us that are kind of embedded into the hybrid approach, would this be the type of anatomy where that would be helpful?
Well, the HCR is a great technique, but there is a condition sine qua non for to be applied, which is the not ambiguity of the proximal cap. Because the crucial point is to have a good puncture of the proximal cap in order to be sure that you inject, you deliver contrast in a right position, I mean intraplaque. So if the proximal cap is not ambiguous, very well, you can go and you can apply the technique, and you basically dramatically reduce the crossing time of the wire inside the occlusion. If the proximal cap is unambiguous, you have to do all your best in order to solve the ambiguity. And in this sense, you can use an IVUS guided puncture. But the crucial point is, in a way, another way, I mean, directed or IVUS mediated, you need a good puncture. If not, HDR is not a panacea. I mean, as the other technique, the retrograde, the ADR, the anti-gray wire escalation can be applied according to the characteristic of the lesion. In this case, I think there was a big disease of the left main. Probably I would have considered to interrogate better the proximal cap after a pre-dilatation of the left main in order to see better the what is the situation at the level of the proximal cap. In this situation, I think this is a very difficult case, of course, very tough cases. Another comment is that you can also perform the HDR retrograde. So my suggestion, when you cross the collateral and you arrive close to the distal cap, you should perform a tip injection in order to study, to evaluate the morphological characteristic of the distal cap. And if this, the aspect of the distal cap is good to be punctured, you can consider in a different direction the HDR, and it works. What do you think, Salman?
So do a retrograde tip injection before you actually engage the cap, so you can see
the tip injection. The tip injection, which is not a Carlino technique, it's a way to getting information from the diagnostic point of view. To be a good CTO operator must evaluate the angio from different point of view. I discussed with Salman about this aspect. I think that the contrast modulation is also another way to interrogate the artery. We can interrogate the artery with the conventional injection from the guiding, but you can also interrogate the artery injecting inside the plaque. But of course, you need to be inside the plaque.
I just wanted to say this on the retrograde HDR strategy. I think this is also a very new concept, certainly for me. You know, we always, when you get retrograde, I'm sure everyone does this. It's always standard practice to do a tip injection to identify the distal cap, and then we start puncturing, right? You work your way up with your field XTR, your Gaia 2, CP12, Hornet 14, and when that doesn't go, you get your microcatheter in, and then you do a Carlino to disrupt that, and then get the microcatheter going. So now I'm trying to think differently, that before I do that, maybe just engage the cap and do the HDR, because as you said, Mauro, in HDR the contrast comes first, not the wire, right?
That's it.
So it's something to train the mind to do now.
I think
These are two different philosophy of treatment. The Carlino technique you must consider when the wire stops go ahead. And so you need something, a solution for this stop. And basically you modify the contrast wherever you are. You are intraplaque, you are extra plaque, wherever you are, you can inject, you know where you are, which is a very important point because you can be also extra vessel. And then you consider to use knuckle or different kind of wire according to the picture you get after the Carlino technique. Here, my suggestion is to do a tip injection, which is not a Carlino technique because tip injection is for sure an injection in the intralumen, in the lumen of the artery. You get information about the distal cap, and then you consider to puncture it well, the distal cap. And according to that, after the puncture, you advance the microcatheter, and you start again with the feeder or which wire you consider to use it after the same mechanism that we applied in an antegrade fashion.
Okay. So I'll, in the interest of time, I'll just make one or 2 points. I think those points are all well made. As philosophically, or just the CTO PCI philosophy, the cap is more often than not hardest proximally, right? So because the way CTOs grow, there's a lesion somewhere, and as the lesion fills in, it hardens proximally until it reaches a branch, and when it stops. That's why more CTOs start at a branch. Distally, something similar happens, but there you don't always reach a branch, and what you typically have is softer, more recent thrombotic lesions. And so the idea that Mauro's talking about, you do a tip injection, it helps you identify the true cap. Then we probe it with something softer like a Mongo. And once you can get into that cap, then I would do contrast modulation. You're right. Sometimes you'll be lucky, you'll get HDR. So the difficulty that I think you guys had on the way back was you had a hard cap. You can see by the surgeon missed this LED. This LED is underfilled. The whole thing is diseased, even after you stented it. And I'm not sure how viable it is, but it must be viable because you were having all this VT. But the point is that it's very difficult to puncture a very small, tight space. And so what contrast modulation does is kind of, it softens the plaque, makes it a little bit more spongy, and then you might have had slightly more ease in going retrograde. So I'll just speak to the retrograde HDR option. I think you should explore it, and it's a win-win situation. Either you cross or you don't cross, but even if you don't cross, you've made the plaque more favorable for wire passage.
When I talk about future direction with HDR, I alluded just to this aspect. I think I'm very happy to spread this idea even to the Canadian community because, well, this is the original idea. Now we need other brain talking about this idea in order to improve this idea, because my purpose is to simplify what simple is not. We know very well that the majority of patients are untreated because the majority of operators are not able to reopen. And so this is the problem. The patient deserves a good treatment independent of the ability of the operator. If I'm not able to reopen this artery, there are other operators that can do it. But if I try to simplify this system and the HDR mechanism that open doors to the CTO PCI treatment, also to, I would say, beginner operator, even in difficult context, I think that people can add something of personal to this original idea. And for example, Salman helped me a lot in this purpose. For me, I was lucky when I met Salman. Salman is a great guy, is a curious guy, and discussing one each other, we are improving the original idea. Now the Salman is giving a wonderful idea about the opportunity to explore the proximal cap with the IVUS. And now we are waiting for a new guy discussing with us about this technique and considering further evolution.
Sanjay, you got your hand up. Your question there.
Yeah, I have one question and a couple of comments on the technique. The first question I had was for Arjun. I noticed your first attempt resulted in a misfire when you started antegrade. Presumably, you ended up in a small branch where you thought you were along the course of the LAD. I didn't see an injection that looked at your left main as well as your RCA vein graft and your lima. Did you have that?
So you didn't see the injection of the left main and the.
So
Yeah.
what we saw was a duel between the lima and the vein graft. But what we didn't see was sometimes what you need in these post-bypass cases where you have atypical collaterals coming from different locations.
Right.
Is a triple injection where you have your antegrade as well as the two retrograde limbs that are going to light up your total territory. I wonder if with that triple injection you might have had some resolution to your ambiguity, because presumably the angiogram that you saw was very shortly before this man's bypass. And during that angiogram, there was antegrade flow through the left main and into the LAD, which you could see as to and fro flow in the proximal vessel, right? So that shouldn't be gone yet, given that it's fresh. It may be thrombotic because of pressure head changes, but it shouldn't be gone. And so that's the first question I had, just to try to understand resolution of ambiguity there.
Yeah, I went back. We definitely did take the pictures. For some reason, maybe we didn't see them. We were just like, I think we had them as we were working. I actually do wonder on the initial if we were seeing flow from the left main. Like it's hard to know where that LAD cap started. So I think it might have been a more mid LAD cap, like past that diagonal. And so we're seeing
maybe
flow to the diagonal.
maybe yeah, maybe. I guess the challenge is we're not sure, based on the picture that you showed, where that microcatheter was, whether you had taken a small diag or maybe an accessory branch that was very proximal off the left main that we all get stuck in sometimes, right? Because it looks like it's going along the LAD, but in fact it's not. So that was my question about ambiguity. I did this. I've been thinking a lot about these types of procedures lately, and what I realize is that there are three primary goals, right? Safety, efficacy, and durability, in that order. And so from a safety perspective, I like the sort of the retrograde HDR and or Carlino technique once you get into the plaque and your wire isn't moving, because it also helps light up the vessel. And it essentially resolves the structural ambiguity so that you can almost take a knuckle with impunity, so long as you don't have huge branches coming off in the proximal vessel, which we worry about with LADs. And the other comment that I have from a safety perspective, having done this and suffered for it, is if you're very close to the ostial LAD, right? Let's say your proximal cap is at the ostial LAD, and this is, in respect to Salman's comment, where actually this was written about by Srivastava in '96, right? In some of his old pathologic models, right? Where they showed what the proximal cap was made of, and the distal cap being slightly softer than the proximal, but harder than the rest of the tissue plane. If you do a retrograde Carlino with an ostial LAD proximal cap, you can dissect around it and up into the walls of the left main. And I once dissected off multiple branches off of a left main because I did the Carlino technique too close to the proximal cap retrogradely, which was at the ostium of the LAD. And so that was to me was a cautionary tale, and actually changed my practice such that now if I ever do a retrograde, I always have a safety wire down the antegrade limb from the left main into whatever vessel this was. In this case, if you had a graft to the circuit, it becomes less of an issue, but that may not be the case if you're doing a native LAD and you're using this technique. Having said that, I think it's probably one of the most useful techniques to resolve ambiguity and give you actually access to safety that I think we all want to maintain in any of these types of procedures.
You know, can I make a comment on the distal cap or bifurcation? I think 5 millimeters is the limit. If you're 5 millimeters of within that, I probably wouldn't inject. I agree with you because I think the contrast has to decide, just like a knuckle has to decide. And same thing with knuckle, right? If you're coming with a retrograde knuckle, you don't want to like knuckle into the left main because next thing you know, you're in the wall of the aorta. In the same way, if you're doing a retrograde injection, it's only for the cap. I think the way Mauro described HDR and he came up with it, it's a procedure to be done at the cap. If you're close to the distal cap, I think you can predict where the contrast is going to go. But just going back, I think I was going to make the same point because let's forget HDR for a second. Let's just talk about non-HDR classic wire techniques. I think dual injections are important. I think in this particular case, the patient was already on ECMO, so you had the sort of the idea that you could do multiple injections without overwhelming the ventricle, right? So if you have someone with an EF of 20%, sometimes you do a dual injection, they go into VT, and you're like, oh, shouldn't have done that because now their myocardium suppressed. Here, the problem is that because you now had thrombus versus competitive flow, you couldn't see the distal left main as well. And what I may have done, so I'll tell you 3 angles. So LAD ambiguity is very difficult to resolve because of all the septals and diagonals that come off there. And the best way to do that is to test in 3 angles. One is the spider view, one is the areocranial, which you were working in, but the one you often overlook is actually the eleocranial. So steep eleocranial was where you saw the lima going down to the diag and come back up to the LAD ostium. And once you do the retrograde injection, you can then direct something like a Gaia towards the cap as opposed to pushing a pilot 50 or 200 in an areocranial view. So again, just a stylistic thing that if I was doing this with the wire-based technique, I do think that as Mauro pointed out, this was not the best case for upfront Carlino in an integrate or more HDR in an integrate direction, but I would have done dual injection and maybe used a Gaia to direct towards wherever the retrograde portion was.
Okay.
And last thing I wanna clarify is this. When people talk about the Carlino technique, you describe this technique like a micro dissection. Well, the purpose of the Carlino technique is not to be a dissection, even micro dissection. The reason why I inject a very small amount of content is just to avoid to create the dissection. And if you are extra plaque when you do the Carlino, you realize that you are extra plaque, but this is not a dissection. You basically confirm that you are extra plaque. But the purpose of the Carlino is to do a very small injection. So the reason why I wrote the letter to Eurointervention is because people describe the Carlino technique, and I don't talk about the HDR, but the Carlino technique is by definition, due to the fact that I inject a very small amount of content, is not a dissection action, is not a micro dissection. I don't want to dissect. I realize that I in a place where I can dissect is if I advance my guide wire or if I inject a big amount of content. But by definition, the Carlino technique must not define as a micro dissection maneuver. It's not. It's very important because if you understand the mechanism of this technique, which is small, the crucial point of, or for the HDR or for the Carlino technique is to inject the minimal amount of contacts that can give you the correct information you need in that situation. Okay, that's important. It's not a dissection because if not, and that's the reason why I like to discuss about the history of the contrast modulation. At the beginning was a method to reopen contrast guided star. It was conceived as a technique to reopen artery, but in an era without microcatheter, without dedicated guide wire, and so on. So there is no opportunity, and I try to do all my best with the limited devices I got at the time. Now the scenario is completely changed, And if you use Carlino, Carlino is a useful technique, but if correctly applied, I mean, with a very small amount of contrast. So less than 0.5 milliliter is amount of contrast that does not preclude the beauty, for example, of the HDR. And that's the reason why I consider it as an upfront technique and not after failure of the other technique. Because if you go with the anti-granular escalation and you go somewhere, you create subintimal hematoma, you modify the environment in which your system must work. And you have to consider that I want to involve the soft part of the plaque. So I have to be very precise. I have to know where I am. And that's the reason why I do a small injection. And that's the reason why I appreciate all the descriptions Salman do even on a social platform, because this is a new alphabet. When you start talking about in Chinese, you need to know which is the value of the letter they write, which is not the same in us. It's a different way of seeing the same problem. You know what I mean? So now we have to start to understand the vocabulary of the contrast. The contrast in another way, which is a different way, not from the guiding, but from the microcatheter, give us very important information. You need to understand the meaning of the contrast, such as we need to understand what the Chinese say in this strange language.
I'm just going to make
got two more presenter cases to present.
Sure,
So, Bilal, you want to present the next speaker?
Yes. So I was just going to say we'll move on to the next speaker, and we'll have more time for questions, of course. We're going to pass over to Charmaine Thiru. She's our interventional fellow who's from the UK. She just completed a year with us, and she's turned into a great operator. She's going to present a PCI to RCA CTO case. And I think Bassam will moderate this. Ram Vijayagaravan, who's now joined us, unfortunately couldn't be with us in the beginning because I think he had a family situation to deal with at home. So I'm still very grateful that he's kind of joining us and hearing us in the background. So thank you, Ram. So anyway, over to you, Charmaine, and Bassam. I'll leave you to moderate.
That's good.
Thanks, Billy. Can you guys see my screen?
Yes.
Okay. So this case is essentially using a retrograde approach via the LCX PLV epicardial to treat a CTO RCA. A little bit about background. So this gentleman has a history of hypertension, hypercholesterolemia. He's 72, and he presented earlier this year with an anterior STEMI, which turned out to be quite complicated, PCI to his LAD-D1. He also had an RCA CTO, and at his index presentation, his LV function was severely impaired. I'll present the index procedure, but moving forward 12 weeks when he was seen at clinic, he was still persistently breathless and fatigued, despite us swapping his ticagrelor to clopidogrel. His BNP was normal, and he had a large burden of ischemia in the inferior lateral territory. So we plan to bring him back to fix the RCA CTO. So this demonstrates that the RCA is dominant. You can see that there is a CTO involving the proximal cap. It's blunt. We thought the occlusion was quite long, and the vessel is quite diseased distally. The left main stem is normal, and then it follows through with a very aneurysmal circumflex and LAD. The culprit was this thrombotic lesion in the proximal LAD, which we intended to treat with one stent. So we deployed a 3.5/22 into the LAD, and subsequently we felt that the diagonal was pinched. You can see it's slightly hazy. We wired it and continued to post-dilate the LAD stent. We then performed KBD, and after that, we felt that the diagonal looked slightly hazy, and it looked like it was dissected. So we planned to stent the diagonal with a tap technique. However, as we were delivering the diagonal stent, everything fell out. The guide and the wires fell out. And we realized that the stent had actually come off the balloon, and it was impacted in the aneurysmal section in the left main stem. You can see it's here in the left main stem. The stent was there. So we tried multiple techniques. We tried wire wrapping to get it out, and we also tried the micro snare, but to no avail. At this point, he had ongoing chest pain and lateral ST elevation. The diagonal was clearly dissected. We needed to treat it, but we thought that we needed to secure and fix the impacted stent. So we stented left main to LED with a 50/30 onyx. Fortunately, the stent was crimpled in the proximal circumflex, and we were hoping that it would just, remain there and not get displaced anywhere else. We then noticed that the flow was getting worse in the diagonal, so we went ahead to perform the tap technique, which we intended to do beforehand. So we used the guide liner and we deployed 2 stents in the diagonal and performed KBD LED diagonal. And then when we thought we were done, we were not done. The guy had pain in his, more pain and anterior ST elevation. His vessels were quite friable because whatever we ballooned seemed to affect the distal segments. You can see again in the LED, there was dissection. So we just went ahead and put 1 stent in the mid LED and we dabbed the distal LED. And that was the final result, which was quite satisfactory. So moving on, when he came back for his planned procedure at 3 months.
No, for the hard stuff.
The hard stuff, yeah. So yeah, we just did relook angiograms and the stents were patent, both LED diagonal. We just performed some IVUS guided optimization. And you can see, thankfully, that crimple stent was still there. It wasn't dislodged anywhere else. These were the setup angiogram shots. So we just put a balloon in the conus just to stabilize the guide on the right-hand side. This the REO cranial shot is quite good because it essentially shows the epicardials that we were planning on using. So there's 2 epicardials from the proximal circumflex, the lateral epicardial and the medial epicardial, which connects to the PLV. This is a map, and this was the medial epicardial that we intended to use if we needed to go retrograde that connects to the PLV. So we tried antegrade attempt first. Again, like I said, we secured the we put a balloon in the conus to try and stabilize the guide, but the occlusion was quite close to the ostium and it was a very tough cap. We tried multiple wires, but it was very, very difficult to puncture and there was quite poor support. So we thought we'll just proceed to the retrograde approach, which we have.
So Sharmeen, I'm going to ask there, Salman and Mauro, like, is this the type of cap where, if you're not able to puncture at all, would it be still worth trying to get some HDR going, or you need to embed the microcatheter tip a little bit before it's useful?
Let me go back.
So I'll make it, in the interest of time, I'll make it quick. So you don't want to waste all your time trying to get a cap that's not there. Typically what I do in these situations is I'll do a tip injection like Mauro had suggested. Sometimes when you have a blocking or an anchor balloon up like that and you do a tip injection with the microcatheter, you may be able to discern a cap. If that's the case, I might puncture it with a Gaia 2 and then do an injection there. But if it's really turning out to be difficult, I think I would, if there was a retrograde option, I would take that. And I know Bilal obviously is quite comfortable in retrograde. We did have a case recently where we tried aggressively to do HDR and we came up with the worst, one of the biggest stains I've ever seen. We were able to complete the intervention, but turns out that staining was actually an epicardial fat around the RCA and not, because he didn't have any effusion, the RV was fine, the patient's hemodynamics were great. So again, I think if you try to puncture too aggressively this close to the ostium, and if you don't have purchase, see how the guide is not even coaxial with every heartbeat, you just end up with the risk of a misfire.
Fair enough.
I fully agree with Salman. To consider the HCR, you need much more information from the view I seen in this angiography. To be honest, is very difficult to understand the true aspect of the proximal cap, and even the tip injection could be another option that people should consider in order to well evaluate the proximal cap.
I just wanted to say, in this particular case, what hasn't been shown, just for time's sake, is that actually we felt that we may have punctured the cap. We did deliver the microcatheter, and when we injected in an attempt to disrupt and do the traditional Carlino, it just turned out to be a tip injection to identify a blunt cap. So wasn't particularly useful. So anyway, I'll leave it to Charmaine to tell us what she did.
So then we opened up the stent struts into the circumflex to allow epicardial access. And again, the epicardial that we intended to use was the medial epicardial. We were quite fortunate because it was sort of adjacent to the crumpled stent. So when we advanced the pilot 50, it sort of deflected away from the stent. We carefully navigated the turnpike LP onto the proximal bit of the epicardial. And at this point, we swapped it for a SO3 wire. And we advanced the SO3 wire down to the distal portion of the epicardial and, controlled wire tracking and controlled turnpike LP tracking down to the distal PLV at this point, and we swapped it to a Sion black. We then did a tip injection, and it clarified that we were in the architecture. The cap was very tough, the distal cap. We tried many Carlinos. We tried a Gaia 3, a CP12, and a Hornet 14 to puncture the cap. We made some progress with the microcatheter, and then we did a repeat Carlino at this point. We managed to puncture the cap with a CP12, and this advanced into the aorta. At this point, it was quite difficult to push the microcatheter, but we tried to do controlled pushing. And as you can see, the ABU4 guide is prolapsing into the aorta. And this guy had severely impaired LV, and it's just something to avoid. And at this point, we trying to determine if the wire is in the aorta. Again, we're trying to move it to see if it was easily movable. Sometimes we use the microcatheter and transduce it to check if it's in the right position, or we do a small contrast test to see if the contrast is clear or not. Oh, sorry, it's been playing up. Let me just get it back.
So, Charmaine, you trying to bring it back up?
Can we not share the screen?
Is it sharing?
No.
No, we lost your screen there. So what way is, try and take your retrograde guide. Yeah, and back there, retrograde guide, and move it around, see if there's any interaction with the wire. Because, if you're in that position, you're probably going to snare. You're not going to try and, rewire. It will come back and rewire your guide given the whole position.
Yeah. So at this point, we swapped the AL to a GR4, and we tried to snare it. We also swapped the CP12 to a R350 wire to snare with that. We tried for a good 10-15 minutes to snare, but we didn't manage to. So we just assumed that the wire was probably in the aortic wall. So at this point, we swapped back to puncturing the cap antegrately. And it was a bit easier to puncture the cap antegrately, presumably because we had already disrupted the CTO body with, wires, the microcatheter, and the retrograde Carlino. In the second screen, you can see we thought the wires were, in the same plane, but at the same time, we were a bit apprehensive to pursue an antegrade approach because sometimes it can be a bit misleading. And, we were unclear of the trajectory of the CP12 wire. We also thought if we pursued a retrograde approach, then, we'll get the best support possible with the externalized wire. So we did that. We got the retrograde CP12, and then we got the Gladys MG into the integrate guide extension and did a guide extension facilitated reverse cut. We then externalized with an R350. And this IVUS just shows that the wire was actually intraplug throughout. In the interest of time, I just won't play it. And 3 stents later and 1 DCB later, we managed to get the vessel open. We then, just post-dill the left main stem LED stent because we had wires and microcatheters through that. We reviewed him 6 months later. He was asymptomatic. He's still on DAPT. Fortunately, his LV function has improved and it's now normalized. He came back actually last week to get a check angiogram just to assess the stents in the LAD left main stem, and also that crumple stent that seems to be quite stable there. And that's the result of the RCA. We had to optimize the mid portion because we put a 3.5 stent at that point. So we post dilated it with a 4.0 and depth that portion. Thank you.
Great presentation, Charmaine. When you injected retrograde, you said that you did a Carlino. Mauro, is that the proper way to do a Carlino? Like it looks like it gave them a lot of information about the course of the vessel. And how does that different from what you're saying is not a Carlino? When I'm subintimal, I'm knuckling, I'm trying to get and I can't get my knuckle to progress because of calcification, and just take a 3cc inject hard to try and soften that part,
And this is
which
the
is
last
kind of a
resort
different goal.
when this is the last resort. When you inject a lot of contrast, means that I don't know what I have to do. Let's try with a big amount of contrast, and you basically you do not perform a Carlino, but you perform a contrast guided star, which is
Fair enough.
and it is a different the different mechanism. I didn't see the Carlino. They alluded to the to perform a Carlino, but I didn't see any, because I like to discuss also the technique specifically. But what is the beauty of the technique? It helps a lot of operator when they are in a trouble. The most important information, the first important information you can get from a Carlino, and where I am. You have to have an answer to this question, because if you know where you are, you basically, first of all, you reacquire confidence in going on. And second, you can also consider alternative strategy. Could be knuckle, could be aggressive guide wire, whatever you can choose could be correct, but it's not predictable, because it's according to the different situation you can get in different CTO. The important is to understand which is the mechanism of the contrast. The option are information about the position, opportunity to modify the plaque when there is no other alternative to go ahead, and using the contrast as a mean to progress, because the contrast usually is less aggressive than the guide wire, particularly in a subset of high calcific situation. And injecting strongly, you basically favor the address of the contrast towards the side of the artery, and so towards the extra plaque space. And this is another opportunity you can get, because when you have to reopen an artery, you have to consider the vessel architecture. If you stay inside this architecture, you are in a safe position.
Fair
I
enough.
just want to add a comment about the Carlino. I would say that was a Carlino. I think we'd back to 6 or 7 Carlinos, and we were desperate because nothing, even a Hornet 14 would make no progress, but it worked. So the other point I'd like to make is the passage of the retro wire in the aorta. I actually thought I was through. Time doesn't allow, but I've actually stored that fluoro, that wire, that movement that wire makes. I've done quite a few of these now. And even when I have captured it and I've done the IVUS, I believe that I've been, in some cases, maybe 8 to 9 millimeters in the wall of the aorta. And you can tell that from your IVUS that you do. So there was something about this case where I could move it in any one place. My microcatheter transduction wasn't very good. So I decided that I'm just going to use that as my marker wire, and I'm going to switch to antigrade and use it. And that's why I didn't pursue too long. So I set myself a rule: if I can't snare it in 15 minutes, I'm not going to bother. And my retro wire always took the same passage in the aorta. I couldn't get it to change anywhere else. So that's why I was a bit I switched tactics, because I didn't want to cause more harm. We already had a guy with severe LV dysfunction, and I didn't want to create more chaos. So so that was the reason.
The first procedure was fun, was quite fun as well.
I thought I saw one of those 6 or 7 injections that I asked Charmaine to pull that up. I think I saw Carlino injection in her slides, and I thought I saw a branch pop up also. And just the point I want to make to that is, if you do contrast modulation, whether it's extra plaque or intraplaque, and you see a branch pop up, that usually means that somehow, somewhere you've connected to true lumen. So
Cool.
no,
True.
yeah, and the other thing I'll tell you, when you talk about STAR or contrast guided STAR works when you go from hard to soft because contrast breaks into soft. STAR does not work retrograde when you go from soft to hard because hard does not let contrast come back in. So just as a general rule, STAR works best, or contrast guided STAR works best when you go antegrade to retrograde, but not when you come in the retrograde direction, in my experience. There you go. See that? So when you're injecting, so you see the contrast retrograde. So three things are happening. You've got contrast at the tip that makes the cap, infiltrates the sort of distal cap, if you will. Then you see a branch that actually breaks up top and goes towards that balloon that's inflated. And then you see retrograde contrast come down the true lumen and show you that RV branch. So I think you did do a Carlino there, successful.
Yeah, that's great. Now, I just want to tell everyone, Salman is a master of cloud stain analysis. I mean, you show him one little stain, and before you know it, there's like a book written just a little cloud. It's amazing, actually.
I would advise following his Twitter feed or X feed because
I know.
yeah, it is very enlightening.
So Bassam, I think for the purpose of time, we should move on to Mohammed's case.
Yeah.
And this is more along the theme of Dr. Carlino's talk. So Mohammed, over to you. And I think I'll be moderating this one. So go for it. We can't hear you, Mohammed.
Yeah, sorry. Yeah. So thank you very much. Can everyone see my slides there, I hope?
Yep.
Okay. So thank you very much. It's a pleasure to be here, really, and quite an honor to hear Dr. Carlino, Dr. Ryan. Thank you very much. So I'm Mohammed. I'm a second-year interventional fellow at Winnipeg, and we'll be presenting one of our cases. I hope Dr. Carlino will approve because it was a successful showing of a HDR. So I've titled it Breaking Through with HDR, Conquering a Stubborn RCA CTO. Perhaps, unfortunately, I don't have any relevant financial disclosures. I'll jump straight onto the case details. We have a 76-year-old gentleman. He's got all the conventional cardiovascular risk factors and a history of peripheral and coronary intervention. So I had a bare metal stent to the circumflex in 2006 and did well really for the next decade or so, and then had further PCI to the proximal LAD in 2019. Now, at that point, he was noted to have a CTO of the remaining two vessels and opted for medical management. Again, did fine for about 5 years or so until he got to earlier this summer and had a very convoluted kind of hospital admission over the summer with sepsis and kind of lots of acute issues, and ended up having a type 2 MI and a further coronary angiogram just to delineate his anatomy. The two CTOs were there as before, and we noted that angiographically had left main disease that appeared to us borderline. We IVUSed it, and we got an MLA of 6.1 millimeters squared. So because of everything that was going on, he was medically managed and then put through to the clinic just to review how he was doing and how his symptoms were. I'll just add quickly that he had preserved LV function with mild aortic stenosis. So we'll jump straight into the angiogram. When we saw him in clinic, he was very symptomatic with angina, despite being on a fairly good regime of anti-anginal therapy. So this is a kind of first dual injection setup shot that we did. Very similar, in fact, unchanged really from the angiogram in July. So for brevity's sake, I've not shown that. And you can see that the right coronary artery here is a dominant vessel. It's severely diseased to the distal segment, at which point you've got a CTO. There's a blunt cap there and what appears to be a very short occlusion, and filling both from ipsilateral and contralateral collaterals. The vessel that's patent is clearly diseased as well. It's probably the best image I could find of the retrograde supply that we showed, and just to demonstrate really that there aren't very many appetizing
retrograde options there. But nonetheless, we thought, the short occlusion would probably stand.
So the kind of setup at this point was that he had dual access, 7 French systems in both the right femoral and the right radial, AL1 guide to engage the right coronary, and an XP35 for the retrograde injections through the left system. So we negotiated through to the proximal cap with a workhorse BMW wire and a turnpike spiral microcatheter. We did that without any great difficulty, and then we exchanged that out for a Gaia second wire. So we thought, we'd be through straightforwardly, but our progress was somewhat limited by an ambiguous course. Angiographically, it appears reasonably straightforward, but we kept, in the RAO projection that I'm showing here, we kept going into what appeared to be a sizable RV branch. And so that limited us somewhat. So we decided to try really HDR at this point, because after we confirmed we'd engaged the proximal cap, we were unable to cross either using a Gaia second or a Gaia third. Now, the options at this point was that we could escalate to a 14-gram wire, such as a Warrior, but HDR, something we'd seen on Twitter, it's been obviously been published at that point, and we thought, let's demonstrate this as the first example in our center as to whether we could do this or not. Dr. Carlino already gave a very extensive talk about exactly what HDR is, and essentially this demonstrates that low volume, low pressure contrast injection, after a few seconds you can see that there is contrast in the distal lumen. Unfortunately, we don't have the fluoroscopy saved showing that our subsequent wiring, but a Gaia third subsequently crossed the CTO very, very easily. This is a very straightforward kind of application of HDR, and indeed a very successful application. Obviously, I'm not going to go into this in very much detail. HDR obviously is a new technique. The fundamental principle is modulating the soft elements of plaque by injecting very low volume, low pressure contrast. The aim being to delineate microchannels and modify plaque compliance. So once we got through with the Gaia third, our turnpike spiral actually negotiated the CTO very straightforwardly. And then we exchanged that out for a wiggle wire, and really our PCI thereafter proceeded conventionally. So I've skipped forward a few steps just for brevity, and this is our final angiogram. We had to, just given how diseased the vessel was, stent all the way back to the ostium. So it was a full metal jacket. We confirmed our findings with use of intracoronary imaging throughout, and got really very good results. And because it was such a short procedure up to this point, we then tackled the left system disease again with PCI from the left main into LAD without any problems. Patients doing well. So really the takeaway points are that this is a very valuable tool in cases where our anterograde wiring has failed. Low pressure, low volume contrast injection is key. And of course, it's an adjunct to the usual CTO techniques and equipment. So that's the talk. Thank you very much.
Fantastic, Mohammed. Thank you very much for that. One quick question, and then I'll ask Mauro and Salman, anyone else, for their comments. When you did the HDR, did you go straight to a Gaia 3, or did you probe with any kind of softer wires first, or that was my question.
Yeah, sure. I mean, it's funny, I was talking to Dr. Alberuni about this earlier, and I'm sure most of the panel or most of the participants here might have taken a Fielder XT, but we had a Gaia third open on the table. So we thought, let's probe, and actually it passed very quickly, very easily. So we were successful with that.
Yeah, the tactile feedback with the wire crossing makes me feel that even a workhorse wire would have crossed at that point.
Sure.
That's it. Correct. So if you applied, the reason why you applied the HDR is because you prepare the plaque to be crossed. So I'm sure that a good operator can cross with the Gaia 3 the lesion, and I think in good hands you can get in this kind of occlusion more than 90% of success rate. But the meaning of the HCR is to facilitate the crossing with a different wire. If you cross with the Gaia, someone can say that you fix the problem not due to the HDR, but due to the Gaia 3. And
now having just a quick note on that, we had failed to cross with the Gaia 3. So it's not a true HDR in that we tried wire crossing, but we weren't able to make any advancement with the Gaia 3 and I was at the point to pull out a 14-gram wire. And then we said, okay, well, I've seen this technique on Twitter. We'll try it. And then the guy at 3 just flew across.
Fantastic.
Okay.
Mohammed, can you go back to the top of your presentation? I'm going to make 3 quick points, and then we'll come back. So, Mohammed, can you show your presentation?
Yeah.
So the first point I want to make is, why do people who have stable CTOs not respond to medical therapy? And I just want to point out that the RV branch, which supplies the biggest collateral supply to this PDA system, has osteal disease. So just to show you why people don't respond to medical therapy, you can give this person probably all the Renexa in the world, maybe even a Coursera, I don't know, but this patient will always have symptoms because there's just a lot of inflow disease even to the collateral side. So that's the first teaching point. If you can then go to the slide that actually has the Gaia crossing attempt, I just want to make a quick point there. Yes, so the reason your Gaia had difficulty, not this one, the next one, this is our side branch, this is the RV branch. Next one. Yeah, so the reason you had difficulty engaging the cap or puncturing the cap is, look at the shape of the Gaia there. So because of the sort of shape of the lumen, you've got like a secondary curve on the Gaia. So now the Gaia pre-shaped tip is pointing upward at the cap. So had you punctured, you would have by definition been extra plaque. So one of the teaching point here is that wires, even obviously this was a Gaia third, but contrast tends to be more flexible and less judgmental, or at least less assertive than wires. And so one of the things is, even if you can't find the cap, a tip injection might help you find the cap, and then you can puncture it. But the reason but the reason you had some difficulty there, I think, is because the angulation of the RCA is deflecting the Gaia third tip upwards, which is why you're not able to engage the cap fully, because this is probably a softer cap. And the last point I want to make, if you go back to the final image, is the preservation of side branches. So I think for us being purists in trying to preserve, is that more often than not, the HDR, because it takes the shortest sort of route across the plaque, the softest part, more often than not, it will preserve side branches. So if you can see, there's a small side branch that appears just before the PDA in parallel to it. I think had you gone extra plaque and used that 14-gram wire and re-entered by any technique, that little branch may have gone. So again, I just want to point out that one of the advantages of contrast modulation, which is predominantly HDR, is that you are able to preserve side branches. So this is a perfect HDR case, by the way, the perfect first case, but 3 important teaching points.
Fantastic, thank
I'm
you.
just out of curiosity, like talking about side branches in an antegrade case like this, how many people would have wired the RB branch to protect it? Because I know there's different practices, and sometimes the way the patient will react hemodynamically to the RB branch becoming occluded can be quite unpredictable. Sometimes it's forgiving, sometimes it's not. So I just wonder in this antegrade case, just to see what other people are doing, who would have left the RV branch protected.
If you perform correctly the HCR, there is no reason to wire this branch. And in effect, in this case, it didn't wire the branch, and is preserved even after stent implantation. If you are intraplaque, no concern about losing side branches.
I just mean not on the HCR portion, but initially when they're trying to engage the proximal cap, with the Gaia second and Gaia third, and then the Gaias are entering the RV branch, whether a workhorse wire in the RV branch would be something people would do, or is that felt to be not required?
If the CTO attempt was unsuccessful and you had to walk away for whatever reason, or maybe stage it, then I probably would have not only wired, I probably would have pulled by that RV branch, because that RV branch is where the collaterals are coming from. Now, when you fix the RCA, one of 2 things happens. Either you start seeing the RV branch start feeling retrograde, which confirms that yes, the RV branch ostium was critical, or you see what's going on here, which is the RV branch basically becomes now disengaged from the PDA because it's not needed. And so whatever distribution it's supplying is happier just by virtue of the fact that the PDA is not stealing blood from this RV branch. But to your point, if the procedure is less likely to be successful and or if the cap is very close to the RV branch, then it's a good idea to just wire it, if nothing else, as a stabilization wire, and then you can protect it later on.
Yeah, no, I would have wired the RV branch from the beginning, because you don't know how the procedure evolved, right? You can use contrast modulation, it may be successful, may not be successful. And having it protected, there's no harm, And then, as Salman says, doing a POBA, and actually recently I've started doing a lot of jail side branch kissing balloon technique, which of course is also very dear to Salman. It works beautifully. But that is a topic for another discussion, actually. But we'll talk about that sometime. So any other questions? Anyone?
I guess I have a question. So Mauro, Salman, you guys are presented HDR as a something to do as a technique before attempting antegrade wiring, with the caveat that antegrade wiring, trying to do it afterwards if antegrade wiring fails, might commit you to subintimal entry. What about the reverse? If HDR, has there been cases where HDR didn't work and you went back to antegrade wiring with wire escalation, and you found that HDR made it harder? Does that make sense?
It makes sense, but it depends on, okay, so I'm going to say that if you say HDR, then it probably works. So let's just say contrast modulation. So have there been cases where you attempted HDR, but you didn't get HDR, you got contrast modulation, and the wire passage became difficult? So the short answer is no, because if you do contrast modulation, then antegrade wire escalation becomes sort of unnecessary. So the only next step is to either do ADR or do retrograde. And the nice thing about just one or two, because it's a very small amount of contrast, it sets you up for ADR. So you quickly go through that process, because either you get HDR, in which case you don't need antegrade wire escalation, or you see a stain in which you can use the stain as a marker and you can puncture away from it, or do your antegrade wire escalation away from it. Or the stain is in extra plaque and you can just make a little knuckle and set it for ADR. Or you say, you know what, none of this is working, I'm going to go retro. It just makes that first part of the procedure so fast that you shave off time in the decision making. And then like you found that if it works, it takes an hour off your procedure, because then you spend all of your time just fixing the lesion and not worrying about the crossing. So my short answer is no, I don't think it compromises your chances at a wire strategy.
Okay, fantastic. Any more questions? And then otherwise I'll just draw a meeting to a close.
What
Anything,
about to consider to insert in the next future the HDR in the hybrid algorithm? What can we do altogether? Because, for example, the last aspect Salman suggests is very important. So it's a way to rationalize the hybrid algorithm. The beauty of this algorithm is that there is no dead time. So you shift from one technique to another one according to the evolution of the procedure. And in doing HDR, you can, if successful, you reduce dramatically the crossing time of the lesion. If not, you know that you should shift towards an ADR technique or antegrade or retrograde.
I think time will tell. I mean, look at Carlino, when you originally described it many years ago. Now it's incorporated in the hybrid algorithm. I think this is a novel technique. It's a lot of interest. It's a lot of appeal to it. People are trying it. It's successful. So people like it. And I think as we develop our experience, sure, I can see that happening. How can we help? Well, I've already been talking to Bassam. I've been talking to Ram. We're going to be starting doing this more and more. Collect cases, maybe collect a Canadian cohort, a Canadian registry of HDR cases. It's not very hard to do. And just to because what you want is to show the success in different hands, right? In different operators all around the world, in different continents, right? And once you can show that, I think time will just tell, and it will become incorporated into various other algorithms. So yeah, so it's the experience is very early.
The last aspect I wanted to underline of this highlight of this technique is that is a cheap technique, because basically you need a dedicated wire to puncture the proximal cap, a microcatheter, a polymer jacket wire, and nothing more.
Yeah,
Sure.
no, I think that's a great point. And Bassem, I think you should put this on. If you haven't already put this on X or Twitter, you should put it on there, just because I think one of the things that I think me and Mauro are trying to do here, and I'll be honest. I mean, I speak on behalf of both of us, but a lot of what I know has been taught to me by Mauro, and so I think what we're trying to do is make people comfortable with the idea of injecting contrast without the fear that it's going to destroy things, because it's not. So I think case like yours, which is a perfect starting case. In fact, I'm thinking of starting a new sort of X series called My First HDR, hashtag My First HDR, where I recognize people who've done their first HDR. I'm going to actually post one tonight from a guy I've never even met, but he did a really good job. So submit it as a My First HDR and recognize it. But the idea is people should try it, share your successes publicly, but then more importantly, share your failures privately. Message me and ask me. And some people have done that, showed me a bad stain and said, well, what do you think happened there? And so I'd be more than happy to help anyone learn in any way we can.
And
Well,
I
fantastic.
think one of the things that I learned by watching you guys on Twitter and by watching Dr. Fujita's Twitter feed as well is that the HDR technique, you can apply it in series. You can apply it multiple times along a single artery. I find that very fascinating. I actually tried that last week. I did 4 HDR techniques in series. I was able to get through. I think it's just not just once, but you can, if you fail the first time, it doesn't get through, it doesn't mean you can't do it anymore. It hasn't destroyed the vessel architecture yet. I think you can do multiple times. That's something that I observed from your Twitter feed.
Yeah, I just wanted to say, Brian is very keen on HDR, and he contacted me earlier today and was keen to present a case if time allowed. So he has some cases on HDR, and so Brian, we didn't have time today, but hopefully next time when we do another session on HDR, hopefully with Salman on troubleshooting HDR techniques, we will have you present for sure. So look, it's 8 o'clock here, and I know for Dr. Carlino it's 5 a.m. I'm not sure what his plans are to go back to sleep or not, but I just want to thank everyone for their time. Mauro, to start with, to put his alarm clock at 2:30 p.m. in Italian time, for me to ring him up, make sure he's awake. So I was like the alarm clock for him to make it here and look fresh. Thank you, Mauro. Your valuable time means so much to us, and thank you for teaching us about HDR. Want to thank Salman for also sparing the time to join us and to provide useful comments, and we'll certainly be having Salman join us again and teach us more on troubleshooting HDR. I want to thank all the people, everyone, to turn up and find the time in their schedule, particularly our friends Far East. The geography and the time zones, it's crazy here in Canada. So I'm really grateful that we as a Canadian community, interventional community, were here to listen and support Mauro. So thank you so much. Finally, I don't know, it's not finally, I want to thank our presenters for their excellent cases to stimulate the discussion. And finally, I would like to thank Shockwave for supporting this meeting and allowing this meeting to happen. So thank you very much. So if there's nothing else to say, Mauro, any final words before you go back to sleep?
Yes, when I remember when I met for the first time Salman was at the TCT 2 years ago, and we talked just no more than 10 minutes. Well, in 10 minutes, I described him what the Carlino technique was, and he fall in love for this technique, and he started use it basically in a obsessive way. But he was a curious and a smart guy, and from this experience, he got a lot of I would say opportunity to improve, And I'm sure Salman is a different guy respect to 2 years ago. Now he described my technique much better than me. So my suggestion is to be curious as Salman is, because this scientific curiosity give the opportunity to guys that are fall in love for the CTO treatment to improve. That's my last comment.
Thank
Yeah,
you.
and I'll just add to that, guys and girls to fall in love with the technique, not just for the guys, but when you know, you found the one. Technique, I mean. All right.
Okay. Okay, everyone. Thank you very much. And
Thank
Mauro and everyone, we will all be in touch.